And welcome back to the show, spending a little time talking about this CoreValve system with Dr. Peter Fail and Dr. Edgar Feinberg II. And guys, we've been really getting a good understanding of the advantage of this procedure and how it's changed how you do medicine. The fact that it's really, for you, Dr. Feinberg, changed a lot about your surgical practice, that you're spending a little more time in the cath labs working with directors of cath labs like Dr. Fail. And so now this CoreValve device has just recently been approved by the Food and Drug Administration.
Yes.
Can we talk about that a little bit? In January?
Well, in January, you got approval for the extreme risk group. And so we talked about the way the trial was brought out is brought in three different cohorts. So the data was analyzed and presented at one of the national meetings last year. And so the extreme risk cohort, which is those people who were not surgical candidates whatsoever, it was released. And so what my research nurses that I hope are watching right now are
we expect that they are.
Well, they're shaking their head. He says that's not right. But anyhow, what it means is if Dr. Feinberg and I felt that the patient was not a surgical candidate, was absolutely no way we're going to take that person to surgery, we would then go ahead and we were allowed to put them into the commercial group. And it's just a different color box, if you will.
Okay.
Just last week, it actually got approved for the high risk. So now this is a group of patients who Dr. Feinberg would be able to take to surgery at a high risk or do the CoreValve. And I think he would agree that the vast majority of these people would probably wind up doing CoreValve. And there are probably a few patients that, for whatever reasons, we think are not good candidates for that, where surgery is still a better option, whether it's valve anatomy or something like that. But all in all, I think this group now is from an FDA approval standpoint, the extreme risk and the high risk group.
Okay. And now we're waiting for approval from the other cohort, which would be the lower.
Well, the next cohort is called the Certavi group, and that's going to be the intermediate group. Now, the intermediate group is probably another 3 or 4 years away. Okay. And that group of patient really is Dr. Feinberg's bread and butter. I mean, that really is the everyday patient that goes to surgery for open heart surgery for valve replacement. And, at the end of the day, we know we've got a lot of long-term data on surgery, and it's got an extremely good track record. And what you don't want to do is take a procedure that has a perceived less invasive format and supplant it in something that may actually be less efficacious. And so that is something that we need to evaluate moving forward. Is there something about the system that it fails in 15 years? And so you just don't want to just go and randomly just we'll take everybody and just do it. So we really need to evaluate that moving forward into this lower risk category. I suspect what's going to happen in the next 7 to 10 years that this is probably going to be the default therapy for aortic stenosis. Okay. And the people who have open heart surgery are those patients who are going to have bypass surgery at the same time and have their valve replaced. I think this really kind of mirrors what happened with aortic aneurysms years ago, where patients were turned down from surgery and went to what's called an endograft. They went to a stent graft. And now it's the other way around, where they really are evaluated for a stent graft first, and if they don't meet the criteria for stent graft, then they're sent to surgery. And I think that's what we're going to see moving forward with aortic stenosis, is that they're going to be evaluated for a stent valve of some way, shape, or form. And if you're a candidate for that, you go that way. If you're not a candidate, then you're going to go to conventional surgery.
I agree. I think there's certain groups of patients that this therapy is going to be clearly the first round of therapy. Even people that are in middle age or younger, because we're starting to already see in Europe and places, and even here in part of some of the trial stuff, is putting this valve inside of another valve if the valve wears out. We all know most patients who've ever dealt with aortic stenosis and have had a tissue valve know that the risk of tissue valves is they fail or wear out over time.
Right.
And so that leads people to another operation. Well, the beautiful thing about this is if you've got a procedure that can be done relatively simply and safely, and you'd be out of the hospital 2-3 days, and 17 years from now that valve fails, well, you go back and get that done again.
Right.
Much better than having a second surgery, which carries with it almost a 10 times greater risk of major complication.
Right, which is why both of you had mentioned as we were talking today about a previous surgery being a higher risk. And so so this may not be that higher risk down the road.
Right.
Which is what the perception may be about that.
And there's also a group of patients, that's part of the reason why Peter and I are enthusiastically working together. He talked about the patient that might need bypass and a valve.
Yes, sir.
Well, we already understand that I do a large number of bypasses without the heart-lung machine.
Oh.
So if I have this device, and Peter's a doctor like Peter, cardiologists and surgeons that work together like we are, then we could do a valve and a bypass at the same operation without ever stopping the heart or putting the patient on a heart-lung machine.
Wow, now
Which
that's
would save
a huge
a
advancement.
lot of morbidity, a lot of complications.
Wow, because so many things happen when
Well,
so
when
many
you
risk
stop the heart,
factors go up.
It's never
Right.
good. It's wonderful that we can do it, but it's
Right.
never good when you have to have your heart stopped.
Wow, exactly. All right, guys, we've got about 45 seconds. Is there any final thoughts about this procedure, or kind of what we talked about today that we kind of want to wrap up with?
I'm really excited about number one, about the results and being able to be part of this trial with Edgar here. I mean, I think we've had a phenomenal ride over the past 2 years. We've implanted almost 100 patients so far in the Terrebonne area.
Wow.
I've seen a lot of patients from all over the Louisiana.
And I'm gonna take a moment just to give a plug, because the administrative team at Terrebonne General and the board, the hospital, has been very supportive, and Peter and I having this kind of project. And honestly, for us to compete with organizations like Cleveland Clinic, like Duke University, like UCLA, like Johns Hopkins, I mean, it's because we have a forward-thinking administrative team, and we have a tremendous amount of gratitude for that.
Well, and I can tell you, the public, are so very fortunate for you guys, for Cardiovascular Institute of the South, for yourself with your surgery team and Terrebonne General, coming together, really seeing the vision together. And we need all of those working pieces, much like we do with this new procedure and new option. So, gentlemen, thank y'all so very much for joining us tonight. And I know a lot of people learned a lot, and we'll see what your team thinks afterwards. Don't go anywhere. Right up next is Stan Gravwell with sports.